DiGeorge syndrome, also known as 22q11.2 deletion syndrome, is a genetic disorder caused by a deletion on chromosome 22. It's one of the most common chromosomal microdeletion syndromes, occurring in about 1 in 4,000 live births. This syndrome impacts multiple systems, including the heart, immune system, and endocrine glands, making it a critical topic for healthcare professionals. The 22q11.2 deletion involves the loss of about 30 to 40 genes, with TBX1 being a key player. TBX1 is essential for the development of the heart, thymus, and parathyroid glands. This deletion usually occurs sporadically, but can also be inherited in an autosomal dominant pattern. The loss of these genes disrupts the development of the pharyngeal arches during embryogenesis, leading to various congenital abnormalities. Cardiac defects are common, with tetralogy of Fallot, interrupted aortic arch, ventricular septal defects, and truncus arteriosus being the most frequent. These defects can range in severity and often require surgical intervention. Due to thymic hypoplasia or aplasia, many patients experience T-cell deficiencies, which can lead to recurrent infections. Severe cases may present with complete DiGeorge anomaly, where the thymus is completely absent. Hypoparathyroidism can lead to hypocalcemia, causing symptoms like seizures, tetany, and neuromuscular irritability. This condition requires ongoing monitoring and management. Typical facial features include a long face, small mouth and chin, hooded eyelids, and a bulbous nasal tip. These features can vary in prominence. Patients often have developmental delays, particularly in speech and motor skills, and may experience learning disabilities. There's also an increased risk of psychiatric conditions such as ADHD, anxiety, and in some cases, schizophrenia. Additional issues include palatal abnormalities, renal anomalies, and hearing loss, which can result from recurrent otitis media or structural problems. Diagnosis is primarily through genetic testing. FISH, fluorescence in situ hybridization, is used to detect the 22q11.2 deletion. Chromosomal microarray is a more sensitive method that can detect this and other chromosomal abnormalities. Clinical assessment includes a multi-system evaluation covering cardiology, immunology, endocrinology, and developmental health. Family history is also crucial due to the potential for autosomal dominant inheritance. Management involves surgical correction of heart defects when necessary, with regular follow-ups to monitor cardiac function. The degree of immunodeficiency should be assessed, with management including prophylactic antibiotics and immunoglobulin replacement therapy in severe cases, along with caution regarding live vaccines. Calcium levels should be monitored regularly with supplements as needed to manage hypocalcemia. Early intervention, including speech therapy, occupational therapy, and special education support, is essential, alongside psychological support for behavioral and psychiatric issues. Regular screening for renal anomalies, hearing loss, and palatal issues is necessary, with continuous support for social and emotional development. Prognosis varies based on the severity of cardiac and immune issues. However, with early intervention and a multidisciplinary approach, many individuals can lead productive lives. Lifelong follow-up is essential to manage the diverse complications associated with DiGeorge syndrome.